Hi, everyone. Whether this is your first time tuning in or you've been with us before, we're glad you're here. I'm Rahul Gosain, joined as always with my brother and your co host, Rohit Gosain, on our Oncology Brothers podcast, where we continue to focus on bridging the gap between academic research and community practice in cancer care. In this episode, we're covering understanding the side effects our patients face and how to manage them, our ToxCheck series, where our goal is to make sure our patients can safely stay on medications that help them the most. Today, we're focusing on TKIs, tyrosine kinase inhibitors for CML. We'll go through class effects, spotlight side effects that are unique to some of these agents, and talk through strategies for dose optimization. And we're thrilled to welcome not just one, but two hematologists who focus on CML, Dr. Onyee Chan from Moffitt Cancer Center and Dr. Fadi Haddad from MD Anderson. Fadi, Onyee, welcome.
Thank you so much, Rahul and Rohit, for having us today. I'm excited for the discussion.
Thank you so much.
Onyee and Fadi, thanks so much for joining us. Let's dive right in. We have a couple of TKIs to unfold here. TKIs in general have changed the course how we treat CML. And we can only have our patients stay on these therapy longer if we manage these side effects appropriately. And that's exactly what the ToxCheck is all about. For clarity, first generation TKI was imatinib. And then second generation, we have seen Dasatinib, Nilotinib, Bosutinib. And in third generation, we have Ponatinib and Asciminib. Before we dive into each one of them, Fadi, I'll start with you. Any class-wide toxicities, particularly from fatigue, hypertension, GI symptoms, pyrexia, cytopenias, what does that conversation look like in your patient with CML initially, and how do you manage some of these toxicities?
That's a very good question because when I expose the different treatment options for my patients in the clinic, we have, as you mentioned, 6 tyrosine kinase inhibitors that are currently FDA approved. Some of them have distinct toxicities, some of them have similar toxicities. So I go by each molecule and discuss with the patient the most frequent side effects. For imatinib, it's important to know that patients might experience cramps, some edema, some GI symptoms, not much, but we do see that with Dasatinib, we are worried mostly about pulmonary toxicities, pulmonary hypertension, and maybe cough. Some patients should be aware that pulmonary symptoms could happen. Sometimes we do see cytopenias with Dasatinib, and these side effects are particularly seen at a higher dosing compared to lower dosing. With Bosutinib, particularly GI side effect, whether transaminitis, elevation in the liver enzymes, or diarrhea, it's very important to talk about those with the patient and explain the strategy of dose optimization, which we will tackle throughout the presentation. Nilotinib in particular is associated with metabolic syndrome, hypertension, diabetes, maybe cardiovascular toxicity. After long-term treatment, like many years down the road, patient should know that these could happen, and we can talk about strategies to mitigate that. Ponatinib can also cause cardiovascular toxicities, hypertension, pancreatitis. And here we talk about dose optimization, the OPTIC trial you were alluding to earlier. And finally, we come to Asciminib. Some say it's the third generation TKI. Some say it's a STAMP inhibitor. It's a new class of drug. It's the only approved drug so far that is an allosteric inhibitor. It can cause elevation in the lipase, sometimes maybe clinical pancreatitis, and some other side effects. But overall, I would say it is generally well tolerated.
There's quite to unpack here, but Fadi, I love where you started, that you sit down with your patients. Keeping your patients at the center of all this is the key. When we're going through the list, imatinib, arguably one of the best tolerated TKIs, especially this has one of the most favorable cardiotoxicity profile. But the reason why we continue to rely on other TKIs is either resistance or even look for that better PFS or deeper molecular response. This is what gets us to second or third generation TKIs. So let's go down the list and go through these side effects. Starting off with Dasatinib, Onyee, some of the common side effects, what can we expect and how to manage these with Dasatinib?
I would say it is a very effective second generation TKI. So I do use that quite a bit. And some of the things to watch out for, one of the more unique side effect is, already mentioned, potentially pleural effusion. People can, I would say, if you look at, we have some internal study that show about like 20% of patient over time, they will develop that. Depending on the severity of the pleural effusion, it doesn't necessarily mean patient have to stop and switch to a different TKI. It can be managed with diuretics or adjusting the dose. That's one thing to be mindful of. Every time I have a patient that I'm seeing for follow-up or starting Dasatinib, I consult them about watch out for any chest pain, shortness of breath that is more than usual, because, then they need to notify us so we can get chest x-ray and do the workup. Other side effects include rash can also happen, which is more or less a class side effect with TKI. So I think any one of the TKI can potentially cause rash or skin problem. The other side effect that is notable is it can cause thrombocytopenia, so low platelets. So that's why it's obviously important to, make sure patient come back for follow-up regularly, monitoring labs and all of that.
Thanks for covering that, Onyee. With regards to the pleural effusion that you pointed out, you mentioned that we don't have to switch to another TKI, but when sticking with Dasatinib, do you dose reduce them or hold the therapy and then resume once the pleural effusion is resolved at the same dose, or how do you manage that?
So if the pleural effusion is, severe to a point where causing a lot of symptoms, I definitely hold it. I don't just reduce the dose. I give them a break for that pleural effusion to resolve, and then, we give diuretic to help with that process. And then when I do restart, if they were on the 100 milligram dose, I consider reducing. Now, keeping in mind that the BCR-ABL also play a role when you make these decisions, because if someone, the disease is uncontrolled, then, then maybe you should be thinking about switching to a different TKI altogether. Or if someone have already tried multiple lines of TKI and, this is maybe their only one that can semi-tolerate, that also affect, the decision if they should continue versus not. Certainly, if someone have very severe to a point where it's not safe to re-challenge, then we would discontinue. But I have patients where they have very mild pleural effusion on diuretic, and then we keep them on a low dose Dasatinib, BCR still in the MMR level, then they're doing pretty well.
Managing some of these side effects along with monitoring the state of the disease with the PCR is extremely important, and also educating the patients is the key here, what to expect so they can report these side effects appropriately. Fadi, moving along into the space of Bosutinib, where bowel side effects is what you mentioned as well that one sees. Any other side effects, and even for the bowel one, how do you manage and some of the common side effects here?
I think it is very important for all TKIs in general that we start speaking more and educating the community about optimal biologic dosing. FDA approved the drugs that were decided in studies, but we know that in clinical practice, and now we have more data published on many of these TKIs, that lower dosing could actually lead to very good results with way safer side effect profile. If we take Bosutinib, for example, in patients who are newly diagnosed with CML, the approved dose is 400 milligrams per day. Do I use this in practice? I always start at the lowest dose, which is 100 milligram, give it for a week or two for the patient, make sure the body's used to it, monitor for side effects, then go up to 200 milligrams per day for another 2 weeks, then 300 milligrams per day for another 2 weeks. Sometimes I do stay at that dose. If the patient is not having side effects, if the patient is responding, then you can keep it at 300, maybe go to 400 if the patient has no side effects at all. It happened to me once when I reached a 300 milligram threshold. A patient started complaining of more fatigue. This led to dose reduction to 200 milligram, and the patient is in a deep molecular remission. So they achieved a really good response at a 200 milligram per day for now a year plus. So not everybody needs the higher dose. If a patient is tolerating the drug very
Right.
well, has no side effects, we can always get to the FDA approved drug with no issues. But at the minor side effect, I suggest doing some dose reduction rather than completely switching to a different class of drugs.
Thanks so much for summarizing that, Fadi. I can't stress the importance of using the lowest dose while maintaining the efficacy as well is the key here. While talking about the most appropriate dosing, going back to Dasatinib, Onyee, what is the most appropriate dose you get these patients started on and then rather up titrate, or rather start at 180 milligrams per day and then down titrate?
So on the FDA label, the newly diagnosed CML starting dose is 100 milligrams daily. Certainly, there are people that I would consider starting even 50 milligrams daily, and there have been studies showing that the efficacy is not compromised at a lower dose. Now, do I do that for all patients? Some I do start with 100 milligram. A lot of it is a balance between the patient's comorbidity as well as their disease biology. Are we talking about chronic phase low risk disease versus potentially CML with high risk features? I might be a little bit more aggressive if patient is able to tolerate. But again, I think the key is really, individualize it for the patient that you're seeing. But I would say that there are studies showing lower dose can be potentially as efficacious.
I love this idea of touching on the dose reduction and where to start. Both of you have touched on reducing the dose. I do want to come back to this again, especially when we talk about Ponatinib in a second. But before that, Onyee, thoughts on Nilotinib?
Yeah, so Nilotinib is interesting. I would say that personally in my practice, I actually don't really use this drug very much nowadays, mainly because with the new approval and then, Dasatinib, some of the other TKIs, I don't I don't typically start patient on Nilotinib. And also some of the administration issue as well, including the fasting, the twice daily dosing. So it may or may not work with a lot of patients, especially if they're younger, their schedule might be a little bit more, you know, erratic. But when I do use them, I think some of the main things I think about is the patient's comorbidity. So if they already have diabetes, metabolic syndrome, hypertension, those are not the people that I want to use this drug on unless there's really no other options. And then there's also cumulative side effect or cardiotoxicity as well, as shown in the longer term studies.
Absolutely.
Onyee, thanks so much for summarizing this. Fadi, what is the most optimal dose that you get your patient started when you're initiating Nilotinib? Not to forget the black box warning here, which is the QTC prolongation and sudden death associated with this.
That's a very important question you're asking, Rohit. So I tend to start at 300 milligram twice daily. I rarely use this drug, as Dr. Chan also mentioned. But in the case of few patients maybe receiving this drug in the first line setting, I tend to start at 300 milligrams twice daily, monitor the PCR every 3 months. Once the patients achieve a major molecular response, which is a PCR below 0.1%, I tend to dose reduce to maybe half the dose, 150 milligram twice daily with close monitoring. Maybe if they achieve a deep molecular remission, we tend to go even lower sometimes, particularly in patients who are older, have some sort of side effects.
This is actually a perfect segue to our next TKI, Ponatinib, where we indeed start at a higher dose and then decrease the dose at the time of response. This drug is clearly potent, but early on, vascular toxicities were problematic at higher dose. Fadi, with the newer OPTIC study, reducing Ponatinib to 15 milligrams after response showed significant improvement in toxicity, which is very much similar with what we tend to see with other TKIs. Can you walk us through how you dose this and what to expect with Ponatinib?
That's very important to talk about. So I'm going to tackle both chronic myeloid leukemia and acute lymphoblastic leukemia. For CML first, this drug was started many years ago. The dose was 45 milligrams per day. It was shown that it was too toxic. The study was stopped initially, the PACE trial. There was a lot of side effects happening, particularly cardiovascular disease. Then the OPTIC trial evaluated a different dosing strategy, not just doing 45 milligram across the board continuously, but maybe doing 45 milligrams. And then once the patient respond, and we need to remember those patients in the OPTIC trial were mostly patients having resistant disease, failing multiple drugs, or having the resistant T315I mutation. So those patients were a heavily pretreated or resistant population, if I may say. So they were started at 45 milligram per day. There was different cohort, or 30 milligram per day, or even 50 milligram per day. But bottom line, if we want to focus on patients who received the higher dose, once their PCR drops below 1%, the dose of Ponatinib was reduced to 15 milligram per day. And this is in an effort to try and reduce the side effect and toxicities from this drug. And indeed, Now we have long-term data, more than 5 years follow-up from that study, showing that patients who received the higher dose, 45 compared to 15 or 30, actually had better response rates as we might expect, but maybe slightly higher side effect profile. However, when we reduced it to 15, we can mitigate some of these adverse events. So in practice, if we want to summarize the data from this study, at least in my practice, and some people maybe won't agree much with that, starting with patients who have the T315I mutation, obviously they need the higher dosing, 45
Yes.
milligrams per day. Once the PCR drops below 1%, we immediately need to shift to 50 milligram per day. Now, in my practice, and this may not be the practice for patients who do not have the T315I mutation, I tend to start at 30 milligram per day and then reduce to 15 milligram per day once the PCR is below 1%. This way, we can mitigate some of those pancreatitis, cardiovascular toxicities. And all my patients, I tend to put them on aspirin, baby aspirin, 81 milligram per day, and some statin, whether atorvastatin or rosuvastatin, to enhance cardiovascular protection and prevent the emergence of cardiovascular toxicities down the road. And I have seen very good results, at least in my group of patients, when I adopt these strategies. Now, if we shift gear to Philadelphia positive ALL, there have been the Falcon trial that led to the approval of Ponatinib in the frontline setting compared to imatinib, higher remission rates. But what we do in now, if we go outside of chemotherapy, we talk about chemotherapy-free regimens with blinatumomab and Ponatinib. The strategy has been to start with 30 milligrams per day, so blinatumomab plus Ponatinib at 30 milligrams per day, and once the patient achieved the complete molecular remission or undetectable disease, then the patient is switched to 15 milligram per day. And with this strategy, we have seen very high rates of complete molecular remission, more than 90%, and excellent survival at 3-4 years of more than 80, close to 90%. Barely any patients, maybe a couple patients needed an allogeneic stem cell transplantation. So with these strategies, we are able to preserve the efficacy of this drug and prevent the emergence of side effects, in particular pancreatitis and cardiovascular toxicities.
Thanks for summarizing that, Fadi. This drug is active throughout all resistant mutations, but managing that side effect profile, because that's why it was rather used at much, much later lines. And now with the ease of side effect profile management after the OPTIC study, and the hope is after this conversation, our community oncologists are feeling a bit more comfortable to rather utilize this in earlier lines. And that's where we have the most robust data for this. But again, long-term efficacy with lower dose seems to be reassuring. Onyee, with regards to our last one here, that is from another third-generation TKI, Asciminib, which was recently approved. We touched on this with Dr. Jorge Cortez as well, which is with our CML treatment algorithm. But for side effect profile, we have to keep myalgias, cytopenias, and pancreatitis in mind, and clinical pearls around this.
So I would say Asciminib, from my experience, is very well tolerated. We do see some of the side effects that you already mentioned. The other one I want to add on is hypertension. I've seen patients developing, if they have some baseline hypertension, then it might get worse, requiring maybe another antihypertensive for control. For the most part, compared to some of the other second generation TKI, the toxicity is quite favorable. If you look at the As4First trial, which is the frontline study looking at Asciminib compared to one cohort, which is imatinib, and then the other cohort of the second generation TKI, the side effect profile, even compared to imatinib, it's really not bad. I have a lot of patients on Asciminib that I start first line as well as in the relapse refractory setting. Monitoring the lipase is important. I haven't had any patient run into pleural effusion issue with this drug or swelling compared to some of these other TKIs. I start patients on 80 milligrams daily, once a day. Depending on the tolerance and their molecular response, there's also an opportunity to reduce those as well. The goal of chronic phase CML, whether patient is young or old, the idea is try to keep them on the drug with minimal toxicity, increasing their quality of life, and potentially try to get them off the drug, treatment-free remission.
Thank you, Anya. Given it was now approved exactly a year ago, this is something that we're seeing more and more in our clinic. Keeping these clinical pearls and financial toxicity in mind is important. Fadi, before we close, any final thoughts on TKIs or anything that we missed here?
I think we went over the 6 drugs, maybe a take-home message for everybody out there. Before we switch to another drug, we should always check for drug interactions, number 1. And number 2, try and dose reduce. Make sure the patient has better tolerance of the drug while maintaining efficacy, as Dr. Chen mentioned before. Make sure the transcripts and the PCR levels are still stable or improving. Always consider that before switching to a different class of drugs. This is very important.
Absolutely. And one thing more to add, looking for that NGS to make sure we're not just recycling our TKIs if something is resistant already. Anya, Fadi, thank you so much for walking us through these practical insights and how to manage some of the common side effects with our interventions when treating patients with CML. For our listeners, let's go over a quick recap. Today, in our ToxCheck series with Dr. Onyee Chan and Dr. Fadi Haddad, we've covered tyrosine kinase inhibitors used in CML. We touched on class effects to unique challenges and clinical pearls in managing these TKIs.
Educating patients on what to expect seems to be a common thread in all these conversations. For TKIs, myalgias, GI symptoms, and fatigue are few things to keep in mind. With newer TKIs, such as Asciminib, look out for pancreatitis, whereas for Ponatinib, dose reducing to 15 milligrams after response to decrease the incidence of vaso-occlusive side effects is extremely critical. Thank you so much for joining us. If you found this discussion helpful, check out other ToxCheck episodes on antibody drug conjugates, CAR-Ts, and much more. We are the Oncology Brothers.